first of the ECA webinar series. We're starting off with workforce development and health service delivery, showcasing the work of our EC Australia partners. It's a particularly important session today because we're actually focusing in on those non-lockdown states. So for us in the on the eastern seaboard, to remind us that work has continued. There's a lot of work that's been going on in Victoria and New South Wales, but it's going to be really fabulous to focus on those states that have just had smaller lockdowns than we've had to deal with over here in, on the other side of the country. So very pleased to welcome you all today. I'd like to begin by acknowledging the traditional custodians of the land in which we're all meeting. For me today, that is the Wurundjeri people of the Kulin Nation, and I'd like to pay my respects to their elders past, present, and those who are emerging, and welcome any Aboriginal and Torres Strait Islander people joining us today. I'd also like to acknowledge all the people who have lost their lives to hepatitis C and liver disease over the years. We acknowledge and we thank the people with lived experience of Hep C who've generously participated in research and their contribution to progress towards hepatitis C elimination. These are real people with real lives, and that really give our work meaning. And we're incredibly grateful and like to acknowledge their significant input. So today it is all about EC Australia, and as I refer to it as our big workforce development health service delivery family. And we have 21 projects that have been working tirelessly over the last couple of years. We are beginning to see some of them finish, which is very sad and emotional. And we've been having lots of final meetings with some of those projects. And we really look forward to hearing about all of the projects that have been doing incredible work over the last 2 years under very challenging circumstances. But first of all, today, I wanted to just thank all of our partners, but highlight the 3 partners in particular that are going to be presenting today. So we have WANADA, the Western Australian Network of Alcohol and Other Drug Agency. We have the PROMPT study from South Australia, and we also have the Northern Territory Elimination Project, which is a collaboration between the Menzies and NTAHC. So to begin with, I'm just going to stop sharing my screen so that others can start. I'm going to introduce Kim Ziapur and Susan Holt. So Kim has a background in research and counselling and project work in the alcohol and other drugs sector. She works at WANADA, which is the Western Australian Network of Alcohol and Other Drug Agency. And she supports the quality improvement and capacity building in the AOD sector through and has been running this hepatitis C elimination project. She's ably joined by Susan, who's the System Support Coordinator at WANADA, who's been working alongside Kim in the last couple of months of this project. So over to you, Kim.
Thanks, Jackie. I'm Susan and I'm here with Kim Ziapur from WANADA. We're presenting on our hepatitis C project, increasing access of alcohol and other drug services users to hepatitis C testing and treatment. And we'd like to give thanks to EC Australia for funding this project. We're coming to you from the land of the Whadjuk Noongar people today, and we would like to acknowledge their traditional custodianship of the land and pay our respects to elders past and present. So giving you a brief outline of Kim's presentation, she'll be talking about what is continuous quality improvement, giving you a project overview, talking about the participating services in our project, letting you know about the capacity building tool and giving you a brief overview of the findings. Over to you, Kim.
Thanks, Sue. I just wanted to start with a brief definition of continuous quality improvement. So it can be defined as a systemic cyclic process to identify and action opportunities to enhance quality. The foundation of this project is in CQI. So all the services that were invited to participate were certified against a quality standard and have existing systems and infrastructure to support capability building. A key difference between quality improvement processes for certification and this project is that we facilitated supported reviews on site, and it was made really clear that the reviews were not about assessment, but rather we were supporting them to look at their own processes and identify gaps and barriers and opportunity to improve Hep C care. So it really needed to be a bottom-up approach, so the process stayed authentic. There was also an emphasis on how the opportunities for improvement will be sustained. So this process map is really just to give a visual of collaborations involved and a very broad outline of the process of the project. So effective collaborations were key to the success of this project, and there were a number of collaborations throughout, which you can see on the map, but I'll highlight 2 key collaborations. So we partnered with Peer-Based Harm Reduction WA, and this enabled the delivery of peer-led Hep C training to the services and co-design resources. And the willingness of the WANADA members was critical for the project to work, and they participated often enthusiastically, despite the fact that they were dealing with the impacts of COVID-19 and the implementation of data systems that were getting rolled out through the sector at the time. And when we did the supported reviews at one service, we found that often they wanted us to go and do the reviews at other sites or programs of the same service. So there was a real commitment to the project. So the 26 supported reviews were facilitated at service sites, 14 were pre-reviews and 12 post. So Peer-Based Harm Reduction WA did a review to inform the development of the tool. And we had a non-resi service do the pre-review, and they had online training for the organisation, including at a regional site, but they weren't able to participate in the post-review due to capacity restraints, really. So of the participating services, 12 participating services, there were 4 residential, 2 youth services and 6 non-residential adult treatment services. And there was a real range in the type of treatment services, from prison in reach to residential pathways programs and integrated services, which are government alcohol and other drug services integrated with a non-residential service. And the government service had a medical team, and so it was located on site. So I wanted to touch on feedback on the training, because I think it will help with the interpretation of the findings. The training was really well received. The feedback was overwhelmingly positive, and as you see on those graphs, blue represents strongly agree and red represents agree. So there were 88 workers that participated in the training, and they all felt that the training increase their knowledge and understanding about Hep C and Hep C care, and they felt more confident raising Hep C and available treatments in conversation with their service users. And that quote was really just to illustrate a theme that came through strongly. The workers really valued that the training was delivered by a peer, and she was willing to share her experiences in the training, so that was really valued. So with the capability building tool, it was developed from the DDCAT. So that's the dual diagnosis capability in addiction treatment tool. The DDCAT was familiar to most of the services, so it's been used in the sector for a while to look at addressing alcohol and other drug and co-occurring mental health, and it's a validated tool. And it was also informed by the domestic and family violence capability tool. So both those tools are publicly available. So there's references there if that's of interest. So the tool comprised of 20 criteria classified into the following 5 dimensions. The first was culture and context. So that examined services, cultural and contextual factors that either enabled or inhibited the capability to respond to Hep C or deliver Hep C care. Screening and testing, treatment, information and support, and workforce. The rating scale was 1 to 5, with 1 being an alcohol and other drug focus only. 2 was Hep C aware. So that was generally when they're aware of Hep C, but the response to the service users was variable by worker. Hep C responsive, which was a more routine response or systematic response, and coordinated care. So, for example, the case of a visiting GP. And integrated care was when there was a Hep C prescriber on site. I think it was pretty important that when we were doing the reviews, we made it clear that it's not about achieving the highest rating. So it was more about working within the service capability and scope to deliver the care. Each service received a report with their average score for each dimension and an overall score. The average score for the 12 services at pre-review was 2.7 in the Hep C aware category, and this increased to 3.1 in the Hep C responsive category at post-review. So this was pretty exciting, and it demonstrates that the Hep C responsive category can be achieved by most service types. The graph shows the average score for the 12 services by dimension at pre-review, so that's the grey line, and post-review, which is the orange line. And the table includes additional data like the range and the number of services that achieved Hep C responsive at post-review. So when we looked at change in the Hep C care by criterion, there was so much rich data in the findings, but for the purposes of brevity, I'll focus on the key findings. So for the culture and context dimension, most of the ratings in pre-review were in the Hep C aware category, and you'll notice that 1A and 1D shifted to Hep C responsive at post-review. So this is a great finding, and it's what we were hoping to see, as those criterion highlight that the shift was cultural, in that there was increasing understanding and importance placed on Hep C treatment, and that it was documented. This change was attributed to the Hep C training that generated discussion among workers and embedding Hep C prompts in existing processes. So the 2 criterion that didn't reach Hep C responsive is funding structure. So that's understandable. It's outside the services control, and display of Hep C information. So that was really because there was a lack of resources for cold and Aboriginal and Torres Strait Islander people on Hep C, and that was required for the higher ratings. For screening and testing, injecting drug use is collected as part of the national minimum data set for the sector, so that was in responsive and remained in responsive. And it became clear in the screening and testing in this dimension that adding a prompt at this stage had a flow-on effect. So there was one service that added one question, which is in the quote there, would you like support with BBVs and Hep C testing? So when that was asked routinely, it was then documented, and then it was included in treatment plans and in case reviews. In the treatment section, 3A and 3B in the Hep C responsive at post-review. This was largely due to the flow-on effect that I mentioned before, and the effect and workers having a renewed focus on Hep C following the training. You'll notice that policies and procedures are in the coordinated care rating. This was because half of the services didn't hold medications on site, and the remaining half that did had the policies and procedures to manage the medications. Information and support. So this was the dimension that had the greatest change. What was interesting about this dimension is that it didn't take big changes to increase capability for all the criterions. So you'll see that for 4C, the availability of peer support, there was a change from Hep C responsive to coordinated care. This was due to including Hep C information in existing peer support groups or referring to support groups at other sites that had done this project as well and had included Hep C in their peer support groups. And for the other criterion, it was about finding opportunities to include Hep C information in existing programs and resources such as information packs for residents and family members. So the final dimension, workforce, the big change there was workers with relevant training and experience in Hep C care, and that was directly related to the training that was delivered. So I guess the takeaways and the learnings that we had for this project is that supported self-reviews allow for collective reflection and awareness raising. So the discussions were really valuable. Interpretation of the criterion could differ between the services, but that wasn't really a problem because it's a benchmark for internal change, and small changes can make a big difference to service capability. And finally, training and capability building have a bigger impact together. So the training increases the awareness and confidence to raise the issue, and the capability building embeds the prompts in the existing processes to make it sustainable. Thanks very much.
Thank you, Kim, very much. This has been one of the projects that we've really enjoyed learning from over the last 2 years. I really invite people to ask questions. So if you pop them in the Q&A, we'll keep progressing through to the other speakers and come back to some panel discussion at the end. So thank you. I'd like to, I realised I didn't introduce myself. Sorry. Jackie Richmond. Hopefully you connected the dots because my name's down in the corner. But I'd like to introduce my colleague, Joe Doyle, who's the technical lead for workforce development, and he's going to introduce our next speaker. Thank you.
Well, thanks, Jackie, and thanks, Kim. Fantastic presentation. I don't think you necessarily need much introduction to our audience, Jackie, but it's great that you introduced yourself. I get to now introduce our next speaker, Lucy Rolton, who is a nurse who's worked in viral hepatitis, hepatology and research in South Australia for over more than the last decade. She's been the lead of the PROMPT study, which is about point of care testing for Hep C in priority settings of mental health, prisons and drug and alcohol. So Lucy, we'd like to hand over to you now to tell us about the PROMPT project.
Thanks very much, Joe. I'm honoured to be able to present a snapshot of the PROMPT study on behalf of the group today. The PROMPT study investigates point of care testing for hepatitis C in the priority settings of mental health, prisons and drug and alcohol facilities. Sorry, I've just realised I might not have be sharing my screen, and I'm just going to do that now.
Thanks.
All right.
It's coming
Hopefully
up.
it's coming up now. Excellent. Sorry about that. On to the next slide. As you can see from the slide here, many services have contributed to the implementation of this project, and they include SA Health, Hepatitis SA, SA Mental Health Services, Drug and Alcohol Services South Australia, SA Prison Health Services, Serco Asia Pacific and the Department for Correctional Services. PROMPT will be implemented over 12 months at 3 sites in metropolitan Adelaide, including a mental health inpatient ward, a drug and alcohol withdrawal unit and a remand centre. The primary objective of the project is to evaluate the effectiveness of point of care testing for hepatitis C on scaling up testing rates and linkage to care. The secondary objective is to assess the feasibility and acceptability of point of care testing for hepatitis C. The PROMPT model is very simple. Following pre-test counselling and obtaining verbal consent, hepatitis C antibodies are tested using a finger prick blood sample. Hepatitis C RNA testing is performed for all participants who receive a positive antibody result. During testing, a short survey is used to assess the participants' knowledge about hepatitis C, transmission risks, and treatment. At both the Remand Centre and the Alcohol and Drug Service, the nurse works with peer educators who also recruit, conduct testing, and provide education and harm reduction advice. All results are discussed with participants, and positive results are shared with the on-site healthcare team on the day of testing to enable effective treatment planning. Data is collected in a customised REDCap database. And on the right here, you see an example of the poster that we used to advertise the prompt study. We put it in various places at each location, and we found that this was an effective means of raising awareness about what we were doing. Prompt uses the Abbott ST Bioline Hepatitis C antibody test that takes a minimum of 5 minutes to produce a visual result, 1 line for negative, 2 lines for positive. Following a finger prick from a lancet, 10 microliters of whole blood are applied to the cartridge, and a diluent catalyzes a lateral flow. And in this slide on the left, you can see the fluid beginning to emerge just over a minute into the testing process. And on the right, you can see we're about halfway through to the 5-minute minimum mark, and 2 lines have appeared, indicating the presence of hepatitis C antibodies and that a hepatitis C RNA test is required to ascertain infection status. 100 microliters of whole blood are required for the GenExpert hepatitis C viral load finger stick test, and that takes an hour to process a result. Given that these systems will be rolling out nationally, we also wanted to share from our experience adjustable lancets, warming hands, and using gravity to encourage an effective bleed are some of the tips that we've learnt from this process. And on the left, you can see collection of the whole blood in the Minibet, which is then applied to the cartridge in the centre and then loaded into the system. These are our interim results for the first 6 months of project implementation. From October 2020 to April this year, 707 people participated in prompt testing. There's no specific criteria for prompt, as the sites selected were deemed to deliver services to populations at risk of hepatitis C. The majority of testing and positive cases found occurred at the Remand Centre. Prompt was also conducted at a drug and alcohol withdrawal facility twice weekly, where individuals were approached directly and invited to participate. Same-day results have enabled more effective discharge planning in this setting. Weekly prompt sessions have also been delivered at an inpatient mental health unit. Admissions are generally longer here, and the nurse worked closely with staff to ensure that consumers were well enough to consent to testing. As you can see from the overall data, the percentage of RNA positive cases has been lower than expected. Testing will be complete by mid-December, and the final results will be reported along with comparative retrospective audit data. This is one of the prompt peer educators, Lisa Carter from Hepatitis SA. She's standing outside the Remand Centre, where prompt has just concluded after 12 months of twice weekly testing. At each session, 13 to 26 prisoners were tested within units that house anywhere between 20 to 55 men. Establishing and maintaining good working relationships with prison officers was vital, and their support was especially important after the implementation of the quarantine policy following the most recent lockdown in South Australia in July. After a period of very limited access, we were finally able to offer testing through the cell trapdoor. We relied heavily on officers to open and close the traps in addition to their other duties. We expected that this might reduce testing numbers, as we weren't able to provide the environment to ensure confidentiality, but we actually found the opposite. Prisoners were often happy to talk and have a test to break up the very long days in the cell and to let a bit more fresh air into their cells as well. And we found that we spoke to more prisoners per session. COVID testing and vaccination schedules dominate the health staff workload and diminishes their capacity to attend to prisoners' other health needs, let alone performing routine bloodborne virus screening. Point of care testing has many advantages, but it still requires staff to obtain and process samples and to follow up results. In recognition of this issue, Prompt facilitated the implementation of in-reach viral hepatitis service that will continue regular testing sessions at the remand. Although the final analysis is underway, a preliminary review of both the quantitative and qualitative data indicates that the Prompt model has enabled the maximisation of hepatitis C testing in these priority settings. Point of care testing for hepatitis C has been overwhelmingly positively received. Here are just a few remarks from participants that highlight some of the dominant themes that have emerged in the qualitative data. As one person said, I probably wouldn't go back to get the results. Something else would come up. If it was blood being taken, I wouldn't have done it. I don't like the feeling, but the prick was good. Another person told us, when I stop using, that's when I go and get tested. I don't get tested when I'm using because I don't want them to see the puncture marks. I've been putting this off for 7 to 8 years. Anxiety was also a dominant theme, both in having a test and getting the result. As one person put it, I get anxiety really bad. So if I've got Hep C, I want to know so I can deal with it. In Prompt, point of care hepatitis C antibody testing maximise project capacity and resources. It's not available for general use in Australia, but it's pleasing that Abbott have applied for TGA approval for the SD byline hepatitis C antibody test that we've been using in Prompt, with over 1,500 people tested to date. Overwhelmingly, people told us they prefer finger prick testing for hepatitis C, and for a range of reasons that's reflected in the qualitative data. Undoubtedly, the Prompt model of utilising point of care testing for both hepatitis C antibody and RNA testing, combined with the lived experience expertise of peers, is an effective model for scaling up testing in these priority settings. Interestingly, the number of positive cases has been lower than expected, and we'll explore the reasons for this in the analysis. All sites have been supportive of Prompt and appreciate the importance of testing and treatment, but issues such as high staff rotation and competition from multiple priorities make embedding routine hepatitis screening a challenge in some settings. In Prompt, we found that establishing and maintaining relationships with site staff was vital for access and for trialling new ideas to increase engagement. Movement across services and in and out of facilities is an ongoing challenge to follow-up care. Finally, over half of individuals found to have a current infection also reported a recent history of homelessness, indicating that more testing is needed in this population. For this reason, a Prompt pilot study commenced at an inner city homelessness service at the beginning of November. Participants with a current infection will be linked to care and treatment either via the visiting GP or the community viral hepatitis nurses. And here you can see peer educators from Hepatitis SA, Lisa Carter and Deborah Warnocky-Arnold, outside the Hutt Street Centre, raring to go for another day of testing. I'd like to acknowledge the fabulous Prompt team, Catherine Ferguson, Clinical Research Manager, and Dr. Erin McCartney, Research Officer, both with Infectious Diseases Services at the Royal Adelaide Hospital, and peer educators with Hepatitis SA, Deborah Warnocky-Arnold and Lisa Carter. I'd also like to acknowledge the generous contribution of participants to this project and express our sincere thanks to Josh Dorr and Dr. Jackie Richmond from ECA Australia for their support and expertise, and also the Paul Ramsay Foundation for funding this project. Thanks for listening.
Thank you, Lucy, and just so fantastic you've been so generous with sharing your experiences implementing this product study as we begin to see point of care testing rolling out more around Australia. So thank you so much for your work. Once again, I encourage you to ask questions, and Kim and Lucy will be available afterwards. So I'm now going to introduce Angie Everett and Sal Ederman. So Angie's a registered nurse with over 20 years experience in both the acute and research settings. She's currently the senior clinical community nurse for the Menzies School of Health Research, and she's working on the Eliminate Hep C project in Darwin. She works in close partnership with Sal, who is a peer engagement officer and project coordinator at the Northern Territory AIDS and Hepatitis Council. Sal brings current user knowledge and lived experience to this role, and they're both fabulous and so passionate and creative in the way they go about engaging people for this service. They have pre-recorded, but it gives me great joy that they're actually on the call as well. So now they get to listen and watch themselves, which we all know is not fun. But I'm just going to share my screen and press play and hope, fingers crossed, people, everything works.
Thanks for inviting us along today to share what we've been doing up in the NT. Firstly, we would like to acknowledge that Sal and I today are meeting on Larrakia country, and we'd like to pay our respects to the elders past, present and emerging. And so, yeah, let's tell you what we've been up to. So just a quick overview here of some of the things we've been working on that kind of align with the aims of the project. We've been able to get going a weekly clinic that's been held down in the city through the Northern Territory AIDS and Hepatitis Council. We'll tell you a bit more about stats and stuff and how that's been looking a bit later on. GPs, we've been trying to link in targeting mainly our bigger bulk billing GPs, and had a bit of success with one of them. We've done a bit of education with them. We've had a couple of nurse assisted scripts being done, been out and done their fibre scanning, things like that, sat in on consults. So I think that's been really positive, getting some good relationships happening with those guys. And they seem to be interested in doing a bit of an audit for us. So that's a bit of a work in progress, but we're hoping that will get cracking, and we'll try and get in with some more GPs. But like everywhere else, there's been a bit of a COVID buzz, and I think the immunisation and stuff are just kind of putting things on the back burner for us, but we'll chip away. Working with corrections, we seem to have really good working channels with corrections anyway. And up here in the NT, we're really fortunate that our Hep C within, in incarceration is quite low. So they do a day 5 screening, which is great. Then we have the opportunity, I guess, to bounce on things really quickly. And so there's a Hep C nurse out in the prison who I touch base with regularly. There's, I think there's a couple of people out there on treatment at the moment. So anyone that requires scripting out there anyway needs to be scripted by our doctors. So at the moment, we've just kind of set up that they do the workup, and then they let me know, and then I'll kind of facilitate the script from one of the doctors and get it out there. So that's been really good. Hoping to do some more visiting with clients out there, and that's just logistics, I think, of getting our passes sorted and things like that. But I've been out for one visit, and we've done up our info flyers and things like that that people will receive. So yeah, that's also a work in progress. Establishing our peer support network, that's been great. Well, we did initially start off earlier in the year with 3 staff members, but 2 have moved on to other work. But we're super lucky that we still have Super Sal with us, and she's worth the weight in gold. So we're not letting her go anywhere, and we seem to just be, we're getting by really well with just a couple of us. Just a few pictures here to get more interesting than looking at us. So there's some pictures of our events. We've got our World Hep Barbecue we had earlier in the year was really awesome. We had we did a drive up to AAD and picked up some of our clients, and there was other clients arrived. We probably had another 20 service providers, and it was apparently NTAHC's biggest barbecue they've ever had. So we were pretty proud of ourselves. Ran out of food, which was a bit embarrassing. What else have we got? Just a couple of pictures here of our World Hep night we had down at Parliament House, speaking to the Health Minister. Sal did a great job of promoting the project, and there was some of the local sector there, which was also great. I'm just trying to add on before we talk about the clinic in particular. Just within my role in the community, I guess, now we've kind of set it up with the liver clinic at the hospital, that any of their Hep C referrals kind of just get directly emailed from bookings to me, so I can try and get in contact and follow them up any which way that we can. And a lot of that can be done by phone, I've found, just with SVR bloods for people. And, you know, those referrals that come through that are just on an antibody result and things like that, we can facilitate bloods without people having to come to the hospital. And that's been awesome. People really appreciate that. So that's working well. But otherwise, we need to see them, get them down to the clinic or AOD or go and see people. I've even seen people at Menzies here in our building, whatever works. And, you know, trying to be flexible and out of hours and whatever we can do. So our pride and joy here, our clinic, we've got a picky here. This is our Facebook post that NTAHC kind of do something each week just to put it out there that our clinic's running. Since we started in the clinics in June, we've had 18 clinics and we've seen 62 presentations in total of, I think we worked out there was 52 clients. So obviously some returning for follow-up and vaccinations, which is great. 47 of those have been antibody positive and 12 of those thus far have been PCR positive. Of our 12, we can say at the moment we've scripted 6 of them and 3 of them have completed treatment. We're still waiting on SVR and hoping to script a couple of fellas from last week this week. So that will be 8 out of 12. So I think we're pretty chuffed with that. Main challenges with the people in particular that we can't get in treatment has just been that follow-up. So not having contact details, no phone or phone answering. Driven past addresses where there's not even accommodation there, so that we're trying, but we can't find them. There's a bit of mental health stuff with a couple of people as well, so we're just trying to chip away and yeah, see how we go with that. What else have we got? Oh, sorry. Oh, and so what's been working with the project? Undeniably, the incentives have been our biggest draw card. Like to say they're just there to see Sal and I, but you know, most people's first question is, you know, if you guys doing gift cards. Most people are, yes, they're coming through the NSP and there's lots of promo for our stuff in there and people are coming through. And peer support, that's been a massive winner for us, just having Sal in that space with us. People feel more comfortable. I think she's got a great energy, great stories, and is a real asset to the team.
Just being able to offer a little bit of care to such a stigmatised community goes a long way too.
Absolutely. Face-to-face, as we've mentioned, working out of NTAHC is really great. I mean, it's, you know, well known in town. It's been there forever. People are really comfortable coming through. Flexibility, I think we're really priding ourselves on the moment in our flexibility, not quite as flexible as that picture, but we really are bending over backwards to try and meet people however, whenever, whatever, to try and work out what their barriers are and get them in treatment. And that's, you know, picking things up, dropping them off to people, picking them up for appointments. You're trying to avoid having to come into clinic or come into the hospital. And yeah, just a bit of TLC, I think, and trying to sort out any other issues they've got going on. And that's often done with our care and support team. Transport, yep, that's a bit of a winner. All right, so the kind of main clinic stuff, I'll just pass you over to our wonderful Sal now, she can tell you what we've been up to. Yeah, thanks.
Hi, I'm Sal. I'm working as the peer worker within the ECA project. So engaging within the peer space, what I can offer is I bring with me a lived experience that can't really be taught, and it's not just my own experiences but that of my close friends as well. And we seem to need to be able to do a great deal of myth busting from people that have only ever heard of the previous interferon treatments, and there's a lot of people that are scared to come and engage with that, and so we spend a lot of time talking about how things have really changed. So therefore I'm bringing an empathy and complete understanding to the project. I also bring with me a user knowledge with currency in terms of user trends, shooting styles, even right through to groups of people that might be using together and places that they use as well, and where we could be putting our flyers. The strength of the relationship between Angie and myself working together seems to be that we can cater for just about every kind of client that walks through the door, which is a really good thing. And just again, talking about the working within NTAHC is such a trusted space for people who inject drugs that we're able to discuss quite taboo topics, which is quite welcome by the clients. They seem to want to have that opportunity to talk about injecting practices without judgment. So that's something really special. The personal aspects of peer work means that I'm able to talk about my past in a unique is unique, and it's quite a powerful situation. I can change the dynamics completely when engaging with a client by explaining that I was exactly in their shoes. I have people contact me on social media inquiring about the stuff I'm talking about on there. I'm open about my using past, and people contact me wanting to know about services just for a chat, or right through to help getting into detox and rehab facilities, and I'm happy to do that. Also, quite often within appointments at the clinic, I'm using my network awareness and helping people get referred across to other projects. So I have a real passion for this project overall, because it affects me so personally.
Our dreams
for the future.
Yeah. We hope we can do.
Training up and involving our clients that are engaged is something we really hope to do. We want to utilise this moment and have them spread their positive experience with other people in the community. Word of mouth is a very strong thing in places the size of Darwin. And we are finding that a lot of people are spreading the word on their experience with us and the treatment and service that we offer.
We love to get that feedback from other clients.
Yeah, absolutely.
People are speaking nicely about us, so that's good.
I'm hoping to develop a safe shooting review for people on completion of treatment in a bid to try and ensure that they remain Hep C negative or clear.
Sorry.
And there'd be an opportunity to develop a safe shooting one-on-one session, hopefully to identify any possible hazards of reinfection with clients that have become Hep C clear.
Obviously, you know, and that's a work in progress, as I keep saying, that, you know, trying to get GPs to, you know, cast that screening blanket a little bit further than they have been doing so far. Like where we're meeting at NTAHC is not really capturing our baby boomers as such, so we really need to be working more with GPs to be doing more screening in that sense. Linking in with CDC, like I know there's been talk up here about possibly a project that's looking at getting access to our Hep C notifications through CDC. I don't know if and when that will happen, but that makes sense, and that will be wonderful to see that happening. Yeah.
We hope to continue to destigmatise Hep C across the board.
That is a work in progress.
Absolutely.
And actually, something worth mentioning as well, we've got this grand plan at the moment. We want to try and do some pop-up clinics. So we know that a lot of our priority groups are living out in kind of some of the rural areas of Darwin, like just on, you know, just out of town a bit, and probably aren't likely to visit us in clinic in the city. So we want to see if we can take our service to them. At the moment, we've got a great pharmacist who lives out, who's got a pharmacy out that way, who's willing to offer us a space in his like assessment room out there. So we're planning on going out and doing a bit of health promotion in their little shopping village in the weeks leading up to it, and then just see how we go. Like, yeah, try and run the same kind of service, just doing incentives and getting people to come in for screening. So we'll see how that goes, and hopefully we can take that to other places, but we'll keep you posted on that.
We're really hoping that could be incorporated into a harm minimisation van by taking screening out to all communities and to rural areas. Really hope to become known and be a service that's seen to be approachable without judgment. Maybe establish a harm minimisation ban, including the NSP safe sex testing and possible future health promotions with other organisations. It'd be awesome.
NTAHC's got a van, we just need to fit it out and get some money to get on wheels. We can see what other people are doing interstate with their mobile service, and it looks great, and we'd like to get onto that. But for the moment, that's kind of where we're at, and yeah, we're chuffed. We're loving it, and can't wait to see what else we can do with the project. So thanks for listening to us, and anyone that has any questions or wants to get in contact, yeah, we'd love to hear from you. Thank you.
Thank you.
Thank you, Angie and Sal. Can I ask everybody to put their cameras on, Lucy and Kim and Angie? Angie and Sal, how did you find that experience? They did that in one take. I was so impressed. Press record and they were done. So, look, thank you all so much for giving us an overview of the work. I mean, I should just say that Angie and Sal are only halfway through their project. They're going through all the way to the end of next year because their project was significantly impacted by COVID, obviously in 2020. So I just really, Kim's project is finished. Lucy's coming to the end of the project, but just to reflect on everything that you've been able to achieve is really absolutely remarkable. So I can see, Joe, we've got some questions coming.
We do. Please keep your questions coming through. We'll try and get through them as many as we can in the time we have. All the speakers, you can see the questions too, but there's one that's come up, a theme around how instrumental peers have been in hepatitis C research. How can we ensure that research is a safe and supportive space for peers? Would you all like to comment on your experience with your projects? Maybe if we start with NT, given you've just touched on that in your presentation. Sal and Angie, do you want to?
Yeah, sure. Just in response to the question that's before me on the screen, I just think it's crucial to other peer support workers that are stepping into a project like this to understand how to give the right information to the right audience. So you're going to have to bear your soul a little, I find, and I'm in a situation now in my life where I'm prepared to do so. But I think that's where the power sits with how I operate, is that I'm not shy to talk about the fact that I was a heavy drug user for a long time and that I was Hep C positive, and I think that's got a great deal of power in where I'm coming from. Yeah. Do you reckon to answer?
Yeah. Absolutely. I feel like I've got nothing to say on this. I'm feeling, now that I'm live and not pre-recording, I've gone mute.
Anyone else want to comment?
So not true. Lucy,
yeah, you had peers in other projects.
Yeah. Yes. So Lucy, I'm just wondering about, what was the role that Deb and Lisa played in your project?
Well, they were vital at both the remand and here at the Drug and Alcohol Service. So they would actively recruit, educate, test, and the way that we worked together was that when we were doing the testing, I would conduct the survey, and that would enable them to suss out the participants' level of understanding and then tailor their education towards what they perceive to be that person's misunderstandings or lack of understanding. So that it meant that the very short period of time that we had with people was most effectively used between the two of us. I guess in terms of providing a safe space, I think that's probably something more for a peer to respond to. But it's the first time that I've worked really closely and regularly with peers, and I think it's enabled me to develop respect for and a better understanding of what they do, and then to adapt our skills collectively so that we're able to provide and enhance the experience for the participant or the patient, to give them the very best experience and the best chance of engaging with us, and vice versa. Yeah, so I think it really does, working with peers regularly, closely, adds a lot of credibility to my nursing skills, and it's been a great experience for me personally and professionally.
That's great. Thanks, Lucy. I've got a question here about, and Sal, I'm gonna ask you this question. What advice would you give to services or projects who are starting up to improve their peer engagement or their peer-to-peer work? And I feel like this is a really topical question at the moment.
Sure. I think that I've just been lucky that this lived experience era has come about, and I've been involved in establishing peer networks within the NT altogether. So I feel really comfortable and supported in this space. I understand the and appreciate the huge push for lived experience participants. So you're moving away from the word peer a little, which has allowed me to feel like I've still got currency as in engaging with people who inject drugs in my past now. But the new lived experience brand makes me understand and know that I'm still have currency and relevance to the situation, which is I feel is really good. Sorry, I've lost my way now.
No, I think, and the fact that your title is engagement officer, I mean, that is a real focus of your work, isn't it?
Oh, absolutely. Look, I've got the luck of working within possibly the strongest represented peer organisation in the NT here, whereas it's very unlikely that people are hired or working from here that aren't in the peer space. So I feel very comfortable and supported with here, and I don't know what it'd be like to not work amongst peers. So yeah, that's about all I can say on that. Sorry. It's everyone in this organisation across all programs and projects are peer workers.
Yeah.
Yeah.
It's great. Thank you, Angie. I was just going to ask you, Kim, so, I mean, you referenced the training that was offered, which was also peer delivered. And Gab's just asked, can you provide a bit more detail about the training? What did it involve?
Yeah, sure. It was delivered by Peer-Based Harm Reduction WA, and that was really key, I think, in how well it was received. So the feedback did say that lived experience that she shared was really valuable, but in terms of content, I was able to have a quick look. So she did cover what hepatitis was, liver and liver damage, transmission and prevention, testing, treatment, services for Hep C, raising Hep C, being aware of the sensitivities around it and the stigma associated with it and the impacts of that. So that was really valuable, I think, for the workers.
Well, it really had an impact, didn't it?
Yeah, absolutely. Yeah.
To be able to measure before and after as well.
Yeah, and I would go to services and they'd say that the training was fantastic. Like they just volunteered it, so that, you know, they were really, really pleased with it. Yeah.
Can we pick up on that sort of element of Lucy's projects for some details and some of the questions we've been asked? There's a couple of people wanting to know some of those technical things, Lucy, like whether the time to get the result mattered, whether people left, and that related question there, I think, around the emergency accommodation you had. So do people stay long enough for you to see them, test them, link them, or have they gone by the time all that happens? Can you answer those two?
Yeah, sure, Joe. So obviously at the remand centre, it's a bit of a captive audience situation, although you just never know when someone's going to be moved on and transferred somewhere else. But all in all, we were able to do both tests if required and give that result, and then work with the community viral hepatitis nurses to organise treatment to be delivered to the facility, and those nurses will also track those prisoners if they're transferred to other facilities. So we've had a pretty good success rate in terms of being able to follow those people and start them on treatment. In the drug and alcohol service, also, again, a captive audience. So we haven't had any problems in terms of people waiting for that second result. In the mental health facility, it's a little bit different there. It's an open ward situation, but generally, again, able to follow up with those people. In a couple of cases, I've followed up with them on another day, but generally for all the results, they've been given on the same day as testing. The homelessness service, I think, is going to be a bit of a challenge. because it's more porous. People come for a short time for meals, and they've got other things to do. So I think the dynamics of working in that situation, despite having point of care testing and rapid results, I think that's going to be different. But we're going to be going there regularly, and working also with the on-site nurse and the GP and the other staff in the service to ensure that we're able to follow people up. But we'll have to put other things in place, I think, to be able to give people the best chance of success on treatment.
Thanks, Lucy.
Yeah, Lucy, I was just going to say too, I think it's important to note that your project stopped at the testing, and then can you just explain the referral pathways from there?
Yes, so we're collecting data up until linkage to care, which we define as a person commencing treatment. And we're not collecting SVR data or treatment completion data, just commencing treatment. Because of the length of the study, we weren't able to collect that amount of data.
Thank you. We've got a pretty big question here about, how do we build a peer workforce and how do we develop a professional pathway for peers? And I think that is a very important question. I feel like I spent a lot of the early 2000s thinking about that from a nursing perspective, and how do we build that nursing workforce and the nursing pathway in hepatitis. So unless anybody's got an answer to that, I feel like it's one of those massive questions that we're all thinking about. Sal, fabulous.
Could I just say that there is a certificate 4 that's now available as a peer support worker, as a peer educator, I'm sorry. And yeah, I don't know where it's available in other states, but the if people were to explore their local lived experience networks, it's something that's rapidly growing, and something that I've been involved in, and I know the contacts up here for Darwin, but yeah, I would suggest people look into those 2 areas.
Sal, that's brilliant. And I suggest that maybe if people are keen to follow up with Sal, you are a that'd be fabulous. Thank you very, very much. I might hand over to Joe. As all of our workforce development family know, we're really into evaluation. We've asked you all to evaluate everything, and so we're going to evaluate ourselves. So if Liz, could you launch the poll? We'd be most grateful if you could provide us some feedback. But over to you, Joe.
So that should have just popped up. It's even popped up on my screen, so I might even have a go at answering those questions. But it's fallen to me to thank everybody who's taken time to present today. I know there's lots going on around the country, even though you might be relatively COVID spared. I know you've got heaps of work going on. So I wanted to thank, on behalf of all of ECA Australia, I want to thank Kim and Susan and Lucy and Sal and Angie for your presentations today. I can see a lot of our other EC sites joined in, so I hope they've found that useful and educational. And I think some of those big questions we haven't been able to answer today, but they're really important to take away from and continue to work on. There are ongoing seminars in this series, aren't there, Jackie? You may have more details, but I believe health promotion is coming up next week. So some people may be interested in registering for an ECA health promotion workshop coming up next week with some highlights from EC as well.
So that one, I do strongly recommend people join in. There will be an ECA health promotion campaign that has been developed by a national peer network, co-designed, and will be rolling out in a town near you. So get on board. We're hoping that Angie and Sal will be able to be decked out in all the merch when they go to Berry Springs. And anyone who wants merch, as you can see, everybody wears the black t-shirts, and then we're going to throw some colour into it. Emily Adamson's got some amazing merch coming your way. And then the following Wednesday, we have the Aboriginal Health Plan, which is going to be a really fabulous overview of all the work that's being done, being led by Troy Combo, who's the project manager for ECA. So definitely welcome you to register for those as well.
I also finish and oh, sorry, Jackie, I didn't mean to.
Oh, Joe, you and I were always fighting for oxygen. I just wanted to thank everybody. I want to thank these 3 projects. I want to thank all the others who've joined in today. Josh and I just love working with you and have learnt so much, and just really appreciate your generosity in the way that you share your learnings with all of us. So thank you very much.
I'm glad you did that first, because I wanted to finish by thanking you and Josh, because in a public forum, because I know that you have in the background helped support a whole lot of these, all of these projects. And whilst the projects themselves have led the work and done the work, I know you have been there, Jackie, particularly giving a huge amount of encouragement and support. So thanks to you too.
Thank you, Joe.
Thanks everyone for joining in today.
Thank you.
And I look forward to seeing you next time.
Thank you. See ya.